have developed a concept called Bridgital model. Essentially, what it is, it's bridge the gap between access and demand with a digital bridge. As I mentioned earlier, the current care we provide with the human resources and an infrastructure. Example, a doctor and a clinic, or doctors and nurses and everybody with an infrastructure, or a technician with the lab. That kind of a model with this episodic and disjointed and reactive care, we added 4 layers to this. One we call as a network. It's not just a network of facilities, it's a network of every infrastructure, including operation theaters, equipment, everything, including human resources, any doctor in the world, as well as the practicing doctor in the facility. Second thing, for the first time in the world, we re-looked at every protocol and healthcare clinical process and administrative process, reimagine and redevelop for the new world. And the third one, which is we have developed a technology platform, which is purely healthcare in the center and healthcare intelligent. And there is something which Dr. Ritu mentioned about clinical support system kind of artificial intelligence models, and deeper into that. The fourth component, which is the real change it brings, which is people, we call as a Bridgital people, adding a headcount, adding more people and bringing the cost down is a very, very remarkable method of doing it. And this model we implemented in most of this experiment and gain, and which is what we feel nationwide in India, we are trying to work with the government to make it happen. Just to get what is this Bridgital model, how in real, I want to give a quickly 2 real examples in the world for the audience to get a feel of it, so that it would be very interesting discussions during the next available time. So the number one, I wanted to compare the diabetic care in a regular model and a Bridgital model. See, in a regular model, if we take this patient, the right side, I'm showing a barometer, which is we call as a wellness meter. The wellness level of a person, a diabetic patient, this particular patient lives about in a rural India. He traveled once 20 kilometers to one of the clinic. At that point of time, he was pronounced or he was identified as a diabetic patient. They started the treatment with medication and certain amount of immediate action. And during the period, over a period to couple of weeks, he developed some cold and cough and fever. He thought it's a regular cough and fever. So he went to the nearby pharmacy, which is very familiar, very normal in India to go to pharmacy and ask pharmacist to give a medicine. He took the medicine. Since he is diabetic and there are certain difficult composition, and the antibiotic did not match, and he had within few weeks, he had a major episode of high blood sugar. He got admitted in the hospital, and then the reactive treatment kept on going and not having a continuous care. Over a period of 3-4 years, he developed a blurred vision and permanently become a diabetic retinopathy patient. It's a real life example. And look at in the right side, the quality of life in a level of 5, it has reduced significantly, and rest of his life is going to live like that. When you bring a Bridgital model, of course, the first episode is going to happen. And fortunately, if you bring the care close to the car, in this case, you can do through our mobile van, we identified a patient. Because of proactive care, you can see that sawtooth curve very sharply cutting up, because you bring him back very quickly because you have an engagement going on. And the next episode of regular cold and fever cannot happen without a doctor consultation, because doctor is available for your access. And the third point, which is very important, over a period, analyzing all his behavior and overall coach, managing him, the Bridgital platform clearly recommended that this guy has to be looking for his blurred vision or diabetic retinopathy very early. So never the diabetic retinopathy was allowed to happen. So on the right side, when you look at it, his wellness level is very, very high. So now this is one angle of high quality care, and which is what worldwide everybody is aspiring for. Now this high quality care, whenever I present and talk about it, how much it costs, who is going to provide it, who is going to pay for it. Let's look at it, what happens to the cost. In the first current model, the same patient has to visit a health facility 13 times. In the second model, in the Bridgital model, he has to visit only 4 times. The first model, 384 kilometers he has to travel, it is 41 kilometers. The first model, he has to out-of-pocket expenses is about 28,000 rupees. The second model is only 4,400 rupees. He has to get admitted for 3 days. No admission required because it's a proactive care. He has to spend 15 hours in waiting in health facility as an outpatient. You're only 4 hours because you are already doing pre-planned and most of it comes to close to patient home. 13 days he could not work. Here he could not work only in 5 days. So this is the level of technology intervention can bring in. If you look at the overall immersive model, I will take you totally from this primary chronic care model, a proactive, continuous, coordinated care model on the diabetic patient, to a surgical situation. We adopted a hospital in southern India, a government hospital, cancer hospital. This hospital used to do about 4,000 to 4,500 surgery annually. But the surgical department has about 51 people working. Their overall number of hours, they work about 140,000 hours in a year. Out of that, if you take their OPD time and teaching time and all of it, the surgical time is about 36,000 hours. And then at an average, they do about 3 hours per surgery. That means intuitively, they have to do about 12,000 surgery annually. The reason they could not do it, 52% of an oncologist's time they spend in non-clinical activity. 35% of the time they spend only on administrative activity. By bringing this Bridgital resources, by putting this Bridgital process, by overall managing the care in a continuous coordinated manner, the efficiency is increased. The efficiency is increased by 2.64 times. 260% efficiency increase, which leads into capacity increase. What is the capacity increase? Without increasing any doctor or infrastructure or any clinical resource, by adding few Bridgital resources, from 4,500 surgeries, they could do in the same year about 11,900 surgeries. Of course, the added cost of the consumables and other stuff which is required, medicines required for the surgery. So, the one end I showed from the primary and secondary care on a chronic diseases, another end on a tertiary care in a hospital, how this model really helped us.